All right, welcome. Today we are going to build a really solid clinical framework for a topic that is super high yield for anyone in medicine, pancreatic cancer. We're going to go from the very first suspicion all the way to that huge decision point. Is this patient a candidate for surgery? Let's get right into it.
Okay, first things first, I want this number seared into your brain, 85 to 90%. This single statistic pretty much tells you the whole story of pancreatic cancer. It's the percentage of all tumors in the pancreas that are one very specific disease. So while there are a few different types, one of them just completely dominates the field.
And that's exactly the point. That 85 to 90%, that's pancreatic ductal adenocarcinoma, or what we all call PDAC. So for the rest of this breakdown, when I say pancreatic cancer, just assume we're talking about PDAC. It's the one you're going to see, it's the most common, and it's the most aggressive.
So here's our game plan. First, we'll nail down exactly what PDAC is. Then, we'll get into how these patients actually present, which is really a classic tale of two different stories. We'll walk through the step-by-step diagnostic workup, we'll touch on a few other things it could be, and then we'll end with the single most important clinical question. Can we get this tumor out?
Okay, part one. Let's define the main character in our story, PDAC. What are we actually dealing with here?
So, PDAC comes from the duct cells of the pancreas, the part that makes digestive enzymes. But here's the really crucial part. Look at that last line, desmoplastic stromal fibrosis. That sounds complicated, but what it means is the cancer builds this kind of dense, gritty fortress of scar tissue all around itself. And that's not just some interesting fact for a pathologist. That scar tissue makes it incredibly hard for chemotherapy drugs to even reach the cancer cells.
Okay, on to part two. How do these patients actually show up on your service? Well, in pancreatic cancer, it's all about one thing: location, location, location.
This is probably one of the most important concepts to grasp. A tumor in the head of the pancreas is in a really crowded neighborhood, right next to the main bile duct, so even a small tumor can block it up, causing bile to back up, and the patient turns yellow. And because it happens slowly, it doesn't hurt. That's your textbook painless jaundice. But a tumor in the body or tail, it's got tons of space to grow quietly, without bothering anyone, until it's huge. These patients show up much later with really vague stuff like back pain and a lot of weight loss.
And here are some of the other classic signs you'll see. Asthenia, and I mean a deep, profound weakness, not just feeling tired. Anorexia and weight loss are huge. The pain is this classic gnawing feeling in the gut that just bores straight through to the back. And here's a physical exam pearl for your rounds, Courvoisier's sign. That's when you can feel the gallbladder, but it's not tender. It tells you the blockage is likely from something slow and cancerous, not a sudden painful gallstone.
Right. Section 3. So you have a patient with these symptoms, and your suspicion is high. What's the playbook? How do you work this up systematically?
It's a pretty standard pathway. Step 1 depends on how they present. If they're jaundiced, a simple ultrasound is a great first step to look for blocked ducts. If it's more vague pain and weight loss, you'll probably go straight to a CT. Then, step 2 is the key imaging, a pancreatic protocol CT. This isn't just any CT scan. It's a special, high-res scan designed to perfectly map out the tumor and, crucially, see how close it is to the major blood vessels. Finally, step 3, you need tissue, and the best way to get it is with an endoscopic ultrasound, or EUS. This is absolutely critical because the needle goes through the stomach to the pancreas, meaning you don't risk dragging cancer cells through the abdomen, which can happen with other biopsy methods.
Now, this is a phrase you should burn into your brain. A benign sample does not exclude malignancy. Remember that fortress of scar tissue we talked about? Well, sometimes the biopsy needle just picks up that scar tissue and misses the actual cancer cells. So if the scans scream cancer and the patient's story fits, but the biopsy comes back negative, you can't just drop it. You have to stay suspicious.
And speaking of things that should make you suspicious, here's a classic sign on imaging you've got to know. The double duct sign. It's exactly what it sounds like. A tumor in the head of the pancreas can create a traffic jam that blocks both the main bile duct and the main pancreatic duct right where they meet. When you see both of those pipes swollen on a CT scan, that is a huge red flag for a pancreatic head mass.
Okay, time for a bit of a curveball. Most solid things we find in the pancreas are going to be PDAC. But we're doing so many CT scans these days that we're finding a lot of incidental cysts. And when you see a cyst, that opens up a whole different list of possibilities. So, when you see a report that says pancreatic cyst, what should be running through your head? Well, there are 3 main players you absolutely need to have on your differential diagnosis.
Now, don't get overwhelmed by the table. We can break this down pretty simply.
Just think, serous cystatinomas are the grandmother lesions. You see them in older women, and they're almost always benign, totally harmless. Then you have mucinous cystic neoplasms, or MCNs. Think of these as the mother lesions, found in younger women, and these do have potential to become cancer. And last, you have IPMNs. These happen in older folks, and they definitely have malignant potential because they actually grow from the pancreatic duct itself.
And that brings us to the final and honestly the most critical part of this entire workup, staging. Because once you know it's PDAC, every single thing you do next is aimed at answering one single question. Can a surgeon take this tumor out?
This is the #1 rule of pancreatic cancer staging. Forget how big the tumor is. Size does not matter here. You can have a tiny tumor that's unresectable and a huge one that comes out just fine. It is all about the tumor's relationship with its neighbors, specifically the major arteries and veins that are right next to the pancreas.
So the best case scenario is what we call resectable disease. This means on that fancy pancreatic CT scan, there's a nice clean layer of fat between the tumor and all those major blood vessels. There's no contact, the surgeon has a clear path to get it out.
Then we have the gray area, borderline resectable. This is where the tumor is getting a little too friendly with a vessel. It's either just touching it or it's wrapping partway around it, less than 180 degrees. A surgeon might be able to peel it off, but it's risky. So these are the patients we often treat with chemo first to try and shrink the tumor away from the vessel and make the surgery safer.
And finally, there's unresectable or locally advanced disease. This is when the tumor has essentially choked off a major blood vessel, it's wrapped more than 180 degrees around a key artery, or it's completely blocked a major vein. At that point, there's just no safe way for a surgeon to remove it, and treatment will focus on things like chemotherapy. And this chart shows the harsh reality of pancreatic cancer. Because it grows so silently, especially in the body and tail, the overwhelming majority of patients, we're talking 80 to 85%, already have disease that's unresectable or has already spread by the time they're diagnosed. Only a very small slice, maybe 15 to 20%, walk in the door as candidates for surgery right away. So that really leaves us with the big, forward-looking question. We've just seen exactly why this disease is so deadly. It shows up late. But what if we could find it earlier? As we get better at identifying people with a high family risk, the hope is that we could start screening them. Could we find these cancers when they're still small, still resectable, and completely flip these grim statistics on their head? That's really the holy grail in pancreatic cancer research today. Thanks for joining me.